Well, good afternoon, everyone. I think we're just about at time, so we might kick this mission off. Thank you so much for joining us this afternoon for AADC's latest online event in our series. This one is on applying the new disability support pension impairment tables and navigating income support mutual obligations for alcohol and other drugs clients and information for the AOD sector. So thank you so much for coming along this afternoon. We have an audience of several hundred people again this afternoon. So thanks again, everyone, for making the time to be with us here today. Before we begin, I'd like to acknowledge the traditional custodians of the lands that we're all coming from today. Obviously, that's a lot of different places around Australia since we've got hundreds of people on board. But for me, that's the Ngunnawal people who are the traditional custodians of the land that I'm coming to you from here today in the ACT. And I'd like to pay my respects to their elders, past, present, and emerging, and to all of the Aboriginal and Torres Strait Islander people who are joining us here today. I'd also like to take this opportunity to affirm AADC's strong support for the Voice to Parliament, because I think that's a very important thing that we need to do at the moment as well. And our organisation is very firmly in support of the Voice to Parliament. So this event is about ensuring that clinicians working in the alcohol and other drugs sector have a good understanding of how to use the new alcohol and other drugs specific table and the related guidelines to provide appropriate supporting documentation for clients applying for the disability support pension. We're also going to be exploring what happens when someone on Centrelink payments enters residential rehabilitation or other treatment programs for alcohol and other drug dependence, and the steps that need to be taken to ensure continuity of payments. So there's been quite a number of changes in the landscape in the drug and alcohol sector in relation to these matters in the last little while, specifically and particularly in relation to the new AOD specific table for the disability support pension. Sorry guys, you'll have to excuse me today, I'm just getting over a cold. The beautiful thing about these events online is that you will not catch it from me. So without further ado, I'd like to introduce Alex Abel, who is the branch manager of the Carers, Disability and Student Payments branch in the Australian Government Department of Social Services. And Alex is going to talk about the disability support pension, focusing on the application process and the use of impairment tables. So thanks, Alex. Take it away.
Good morning, everyone. Thank you, Melanie, and to everyone joining us today. My name is Alexander Abel. I'm the branch manager of the Carer, Disability and Student Payments branch in the Department of Social Services. I'd like to start today by acknowledging the traditional owners of the country throughout Australia. We're meeting today on many traditional lands around the country, and I want to acknowledge the traditional owners of those lands and pay our respects to elders past and present. The Department of Social Services has a variety of responsibilities. One of these is to develop and manage income support policies. We work with other departments and agencies, particularly Services Australia, whose responsibility it is to administer these payments. This includes determining who qualifies for the payment based on legislation. They also provide customer support and service access through their Centrelink program. We also work alongside the Department of Employment and Workplace Relations, whose responsibility includes providing services and support for undertaking employment and other related activities. As with other social security payments, legislation for the disability support pension is contained in the Social Security Act 1991. The legislation allows the Minister to make certain instruments to assist with the delivery of payments. The impairment tables are an instrument that contains the medical assessment criteria for disability support pension and can be found in the Social Security Tables for the Assessment of Work-Related Impairment for Disability Support Pension, Determination 2023. The disability support pension replaced what was known as the invalid pension in 1991. At the moment, as at June 2023, the number of disability support pension recipients is 770,000. There have been policy changes over the years, but the intent of the payment to provide financial support to people who, because of their disability, are unable to fully support themselves through paid work has not changed since its introduction. However, the qualification criteria, assessment, methodology, and instruments have been changed over the years, endeavouring to better achieve the overarching intent. Eligibility for DSP is based on functional impairment and ability to work, and not on diagnosis or specific medical conditions alone. The impact of alcohol and other drug use is assessable for the purposes of claiming the DSP. I will cover more on eligibility criteria later in the presentation. The current disability impairment tables came into effect on the 1st of April 2023, with the previous instrument expiring. The tables are the result of a comprehensive review of the legislative instrument, including extensive stakeholder consultation with disability peak bodies such as the AADC, disability advocacy groups, medical professionals, and people with lived experience of the DSP process. Table 6 is used to assess the functional impairment of a condition resulting from excessive alcohol use, drugs, or other harmful substances, or the misuse of prescription drugs. Some recipients aren't solely eligible through an impairment assessed under Table 6 and have other conditions or impairments assessed under other tables. Assessors consider all conditions impacting a person's functional capacity when determining their eligibility and any subsequent impairment rating. A range of information is taken into account to determine if a person meets the DSP eligibility criteria. Other than claim form, the claimant completes. Supporting evidence about a person's condition is required to enable Services Australia to assess whether the person qualifies for payment. Health professionals play an important role in supporting DSP claims, particularly in providing medical information that enables a person's eligibility to be assessed. The impairment tables indicate who can provide what information for the assessment process. The information includes whether a person has received the necessary diagnosis and associated treatments for their condition. Health professionals may sometimes be contacted to clarify or provide further information to complete the process. A health professional may also be required to provide information as part of a formal request for information or as part of an outcomes review process. This slide provides an overview of the DSP application process. Highlighted in gold are the parts of this process where a health professional may be involved to support a claimant. Services Australia have responsibility for administering the payment, including managing the claims process. A claimant generally initiates the claim process through an online, paper, or assisted claim, gathering and preparing the required evidence. Details on types of information and evidence to support the claim will be discussed a bit later. Once a claim is lodged, Services Australia conducts a general medical assessment to see if the person meets medical eligibility. Throughout the assessment process, treating health professionals may be contacted by one of Services Australia's health or allied health professionals or government contracted doctors. They'll ask questions to clarify the medical evidence the person provided with the DSP claim. If required, the Health Professional Advisory Unit may contact the author of the evidence to provide further medical advice. Most DSP claimants are also referred for a job capacity assessment. This assessment provides expert advice about the functional impact resulting from the claimant's medical condition or conditions on their capacity to work. Claimants found to be eligible at this stage may also be required to attend a disability medical assessment undertaken by a government contracted doctor. The claimant is then notified of the claim outcome. If granted, the person starts receiving payment from the date of their claim. In the event a claim is rejected, the claimant has the right under Social Security law to ask for a review of the decision within 13 weeks of receiving the outcome. Review of decisions may occur through a hierarchy of authorised review officer, the Administrative Appeals Tribunal, and the Federal Court. DSP claimants must meet medical and non-medical requirements to be eligible for payment. Claimants must be 16 or older and under 67, which is the age pension age, at the time of claiming. They must also meet residency requirements and the income and assets test. Decisions on medical eligibility for DSP claims are informed by medical evidence provided as part of the claim, as well as assessments undertaken by Services Australia, who employ qualified health and allied health professionals. As an aside, in certain circumstances, a claim for DSP may be granted manifestly. This means that on the basis of the medical evidence alone, the person is considered eligible for DSP without the need for a job capacity assessment or a disability medical assessment, subject to meeting all other eligibility criteria. Manifest grants are made to a person with a terminal illness with a life expectancy of less than 2 years, permanent blindness, an intellectual disability where the medical evidence clearly shows an IQ of less than 70, a condition requiring a nursing home level of care, Category 4 AIDS or HIV, or a condition attracts the Department of Veterans Affairs disability pension at the special rate, which is totally and permanently incapacitated. Where a claimant is not manifestly eligible, they must have a diagnosed, reasonably treated and stabilised physical, intellectual or psychiatric impairment assessed at 20 points or more under the impairment tables, and have continuing inability to work in the open labour market. The continuing inability to work is met if the claimant is assessed as being unable to work more than 15 hours per week in the open labour market within the next 2 years and has a severe impairment. A severe impairment is assigned 20 points or more under a single impairment table. If an impairment is not assigned a rating of severe, the claimant must have actively participated in a program of support to satisfy the continuing inability to work criteria. Generally, a claimant can meet the POS requirement if they have participated in an employment assistance program through a government employment services provider, such as a Disability Employment Services or Australian Disability Enterprise, for at least 18 months within the 3 years prior to a DSP claim. The impairment tables can only be applied if a person has a condition that is diagnosed, reasonably treated and stabilised. The condition has an impact on a person's ability to function, that is, the condition causes an impairment and the resulting impairment is likely to last for more than 2 years. I'll just step through now what each of those terms means in practice. Diagnosed is an appropriately qualified medical practitioner has made the diagnosis and provides corroborating evidence. Reasonably treated is whether medical treatment or rehabilitation has been undertaken and if the treatment is continuing or planned in the next 2 years. This includes the nature and effectiveness of past treatment, the expected outcome of current treatment, any plans for further treatment, and whether past, current, or future treatment can be considered reasonable. Treatment is considered reasonable if it is readily available, not too expensive, is regularly undertaken, and has a high success rate, and has a low risk. Stabilised means all reasonable treatment has been applied and further treatment would not result in functional improvement in the next 2 years. The criteria, in particular the criteria related to treatment and stability of conditions, are interrelated and are not considered in isolation from one another. A condition may also be considered reasonably treated if treatment is ongoing or planned and where it is clear a person's functional capacity is unlikely to significantly improve within the next 2 years, even with continuing reasonable treatment. A medical condition caused or exacerbated by a diagnosed substance use disorder is not considered reasonably treated and stabilised until the substance use disorder has been reasonably treated and stabilised. For example, where a person has a diagnosed but untreated methamphetamine use disorder and they have also have a mental health condition with symptoms of psychosis. In this scenario, their mental health condition cannot be said to be reasonably treated and stabilised until it is established that their methamphetamine use disorder has been diagnosed, reasonably treated and stabilised. Where treatment of a substance use disorder is not expected to lead to any significant improvement of another condition, that other condition can be considered stabilised. For example, advanced stage cirrhosis of the liver will not be improved by treating a person's substance use disorder. As such, the cirrhosis of the liver may be considered stabilised. Once it has been established that a person's condition is diagnosed, reasonably treated and stabilised, their functional ability is assessed under the impairment tables. This assessment determines the level of functional impact resulting from a person's impairment and assigns an impairment rating for the identified level of impact. The 15 impairment tables are function-based rather than condition or diagnosis-based. The impairment tables describe functional activities, abilities, symptoms, and limitations that are taken into consideration when assessing the level of impact of a person's impairment. To select an appropriate table, the loss of function is first identified, and then the appropriate table related to the function affected is chosen. The most appropriate impairment rating is considered and applied. It is important to note that any number of conditions does not always correspond to the number of impairments. A single condition may result in multiple functional impairments. In that case, these impairments are to be assessed on all relevant tables. Where 2 or more conditions have common functional impacts, the overall impacts of the condition are assessed under a single table relevant to that function. A single impairment rating reflecting the overall impact on the affected function is assigned on that impairment table because only one impairment rating can be assigned from the same table. Comorbidities, as well as episodic and fluctuating conditions, can also be assessed under the tables, with consideration given to the frequency, duration, and severity given to those conditions. It is important to keep in mind that 2 individuals with the same condition may not necessarily have the same impairment rating assigned, even though they share the same diagnosis. Some of you may recall previous announcements in the 2017-18 budget that Table 6 would be removed, and early exposure drafts of the tables as part of consultations reflected this announcement. During our consultation process, stakeholders raised concerns that the potential removal of Table 6 would decrease visibility of the functional impact of alcohol and other drugs for assessment, as well as reinforcing stigma for the cohort. The government announced in the 2023 budget that the measure to remove Table 6 would not proceed. With Table 6 remaining in place, the department consulted and collaborated with stakeholders, including AODC, to update Table 6 and relevant guidance material to ensure the functional impacts relating to alcohol, drug, and other substance misuse are recognised and captured in Table 6, consistent with the approach across the rest of the impairment tables. This table is used for the functional impact of the condition resulting from excessive use of alcohol, drugs, or other harmful substances, such as glue or petrol, or the misuse of prescription drugs. Conditions causing impairment commonly assessed under Table 6 include, but are not limited to, alcohol and various illicit drug use disorders, various inhalant use disorders, and various prescription drug use disorders. Long-term impacts resulting from previous alcohol, drug, or other substance use are not assessed under Table 6, but under more appropriate tables depending on the functional impact. These may include neurological or cognitive impairment, cirrhosis or other chronic liver disease, cardiomyopathy, and pancreatitis or other complications of organ damage. Each level of functional impact has a corresponding rating expressed in points in accordance with a generic scale adapted from the World Health Organization's International Classification of Functioning, Disability and Health. The rating system is standardized across the tables as shown on the slide. The descriptors in each table follow an incremental hierarchy expressed, among other things, by the use of terms indicating increasing levels of functional impact in performing certain activities. A large-scale review of the impairment tables was conducted by an advisory committee in 2011, which clarified the distinction between the increments and provided qualifiers. No, meaning none, absent or negligible. Mild, meaning slight or low. Moderate, meaning medium or fair. Severe, meaning high or extreme. And what was previously known as complete impairment, meaning total. The determination of the descriptor for a person's impairment level is based on available medical evidence, including medical history, investigation, results, and clinical findings. An assessment starts by considering descriptors for 0 points, and if the person has more than no or minimal functional impact, the next descriptor is considered until the appropriate one is chosen. The appropriate impairment rating for a person's circumstances is one for which all the required descriptors are met, and it is determined the person does not meet all required descriptors for the next level. To get an idea of the specific descriptors and criteria, here on the slide is Table 6 in a horizontal form. There is a lot more detail in the legislative instrument, which also provides examples and notes under each descriptor to assist assessors in applying the most appropriate points. It is important to note that the examples are illustrative only and are not exhaustive or binding. It is the criteria of the descriptors themselves that is considered. As you can see here, while the 5-point impairment rating requires claimants to meet at least one descriptor, the other ratings require the claimant to meet at least 3 of the descriptors. A key part of the DSP claims assessment process is the evidence provided to support an application. Understanding what evidence is acceptable and what information to provide with the claim is very important. It is not enough to state that a condition is diagnosed, treated, and stabilized by a qualified medical practitioner without corroborating medical evidence. As mentioned earlier, an appropriately qualified medical practitioner must provide the diagnosis for the condition. For Table 6, this may include a GP or a medical specialist, which includes an addiction medicine specialist, or a psychiatrist with experience in diagnosis of substance use disorders. Corroborating evidence includes medical and non-medical evidence and must contain sufficient information to determine whether the requirement for diagnosis, reasonable treatment, and stabilization has been met. This information is a primary source to determine if the impairment tables can be applied, the impact of an impairment, and what rating to assign. Medical evidence must include information about diagnosis, past, current, and future treatment, as well as prognosis for the condition. The evidence must also include sufficient information on the condition's impact on the claimant and their ability to function. A claimant's self-report of symptoms may only be relied upon if there is corroborating medical evidence to support it. Similarly, information provided by carers and support people may be considered as corroborating evidence if it is consistent with available medical evidence. In some cases, you may be asked to provide further evidence for the purposes of a review. For example, if a report, document, or other material contains unclear terminology or lacks clarity. This additional evidence must be lodged by the claimant within the 13-week review period after reviewing a decision on their DSP claim. Additional evidence provided after the 13-week period can only be considered if it shows they were qualified at the date of the original decision. The claimant may be entitled to back payment from the date of claim if the review determines they are eligible. Where a person was not eligible at the time of claim but has new evidence to show eligibility from a later date, outside of the 13-week review period, they would require a new claim. There are several resources available for more information and further guidance on DSP, including the application of Table 6 and the evidence required to support a claim. The Social Security Guide assists the administration of social policy law. Relating to DSP, the guide provides further guidance on relevant policy regarding DSP qualification and the application of the impairment tables. The Services Australia website includes a wide array of pages providing information on the DSP support pension and the process to claim. These are set up as guided experience for both claimants and health professionals. On the website, there are a number of forms and resources, including the medical evidence checklist for DSP, that may assist claimants and health professionals alike with information on DSP. Additionally, Services Australia managed a targeted website for health professionals. Historically, the website has been used in relation to Medicare. It hosts training modules for health professionals to support their interactions with Services Australia. Included on this website is an infographic to assist with DSP claims. I hope this session has provided you with some insights of the DSP claim process and how you as health professionals may be able to assist your clients with evidence requirements. I will now hand back to Melanie and look forward to your questions in the Q&A session. Thank you all for attending today and for all being involved in the discussion. If you have any further questions that we may not have covered in today regarding Table 6 or DSP policy more generally, please email the address on this slide. Thank you again for attending and to the AODC for organising and hosting the event. Thank you.
Thanks so much, Alex. I think that's been really helpful. And just for a few of you who've been giving me some questions in the Q&A already, yes, we will make Alex's slides available on the AADC website after this event. We're also going to be recording the event, and we will pop that recording up on the AADC website on the events page after this as well. So you can go there afterwards or direct your colleagues there to watch the recording of this event and to find other resources that might be of assistance. So now that I've stopped having a coughing fit, in terms of housekeeping, please punch your questions into the Q&A. We won't take questions after each presentation, but we will direct them to the relevant panelists when we get to the panel session. So do not use the chat function, please use the Q&A function, and your questions will be directed to the panelists after the presentations. So Alex may have to run away on us because he's a very busy man today, but we will have with us on the panel Nathan Dean, who is the Director of the Carers and Disability Payments Policy Section, and Sarah Morris, who is the Assistant Director of the Disability Support Pension Project Section in DSS. And they are more than capable of answering any questions in relation to Alex's presentation if he needs to leave us this afternoon. So, in the meantime, I would like to introduce our next speakers. We have a double header coming up here from DEWR. Andrew Wright is the Director of Mutual Obligation Compliance and Policy, and Dan Lausevic is the Director of Assessments and Mutual Obligations. Both of them are from the Australian Government Department of Employment and Workplace Relations, or DEWR. So thank you so much, Andrew and Dan, for coming along this afternoon. We understand as an audience that these policy issues that we're talking about for the AOD sector sit across a range of government agencies in terms of responsibility. And we're really, really grateful that you guys have brought your colleagues along so that we can have a panel session that answers any possible questions that anyone might have. So thanks so much to Andrew and Dan, and please take it away.
Thanks, Melanie. As Melanie mentioned, Andrew and I will be covering mutual obligation requirements today and the compliance arrangements around those requirements, which are both the responsibility of our department, the Department of Employment and Workplace Relations. I'll start off by covering briefly the criteria for receiving unemployment payments. So in order to receive unemployment payments, job seekers or individuals they generally need to meet mutual obligation requirements. And the payments that this applies to are job seeker payment, youth allowance when it's paid to job seekers. You can get youth allowance as a student or an apprentice, but they have different requirements for those payments. Parenting payment once the youngest child turns 6 years of age, and special benefit when it's paid under unemployment payment conditions. Job seekers, in order to receive those payments, they generally need to meet other criteria such as means testing. Services Australia administers the payments, the payment eligibility and generally employment services providers such as Workforce Australia providers or disability employment services administer mutual obligation requirements. Excuse me, sorry, I may not be sharing my screen.
Dan, if you just want to click the share screen button at the bottom of the Zoom window, and then
My apologies. Is that visible now?
not yet, sorry, Dan.
Apologies for the technical difficulties.
Just on the bottom of your Zoom screen, you've got the share screen button. If you hit that, that'll pop up with a few options about what you want to share, and then you can just select the right window and click share.
Dan, did you want me to kick on while you work out the sharing screen?
Yeah, if you wouldn't mind sharing the presentation. I did click share and selected the screen, but it's not working for some reason.
Yeah, I think our IT system might be blocking it, so maybe we should just kick on and we can share the presentation afterwards and just go from there.
Okay, yes, apologies again for the technical difficulties. Hopefully you can still follow the presentation with me just speaking. So in terms of mutual obligation requirements, so claimants of unemployment payments are generally required to engage with employment services before they can start receiving payment. There are some exceptions to this, and that's generally if the person at that time isn't able to comply with mutual obligation requirements, or if they're not required at that time to engage with employment services. The requirements are set out in a job plan, which is agreed by the job seeker, and the requirements may be different depending on the type of employment service the person's referred to. For those participating in Workforce Australia, requirements generally include meeting a monthly points target or 100 points per month, and they do this by applying for jobs and they're credited points for applying for those jobs, and also for participating in activities to improve their employment prospects. So with Workforce Australia, there are two main services. There's one for people who are considered job ready or assessed as having minimal barriers to employment, and these people generally refer to Workforce Australia online, where they self-manage their requirements. And for those who have barriers to employment, they're referred to a Workforce Australia services provider to assist them with addressing those barriers. For those in disability employment services, participants generally apply for up to 20 jobs per month, and the number of jobs they need to apply for can be adjusted to their individual circumstances, and also to participate in activities that they agree to with their provider. Job seekers are generally required to attend appointments with the employment services provider, regular appointments, except those who are self-managing Workforce Australia online. All job seekers, regardless of which program they're in, they're required to accept and commence suitable paid work when it's offered. And I'll hand over now to Andrew, who will talk about the compliance arrangements.
I'll unmute. Thanks, Dan. So yeah, we wanted to talk a bit about the compliance arrangements, which are on slide 4. Now that we've got the IT system. So broadly, we wanted to talk to this a little bit because there's sometimes a perception that if you don't meet a mutual obligation requirement, penalties immediately apply, which is not the case. There's quite a number of safeguards in place to make sure that a person's requirements are appropriate for their circumstances before any penalties apply. So generally, what happens if a person doesn't meet a mutual obligation requirement, they're given 2 business days to either explain why they didn't meet the requirement, and if there's a good reason, then it's a valid reason, nothing occurs. If a person doesn't have a valid reason or for some reason can't make contact, their payment is temporarily put on hold, and generally they would accrue a demerit. Following accumulation of 3 demerits, so that's 3 instances of non-compliance without good reasons, there's an assessment done by generally the person's provider, if they're with an employment service provider, or the digital services contact centre, if, as Dan mentioned, someone is being managed by digital services. And the purpose of that assessment is really to have a look at someone's requirements. Are they appropriate? Is there anything that they haven't disclosed? Do requirements need to be adjusted so that they're achievable for the person's individual circumstances? If the person is found that assessment not to be capable, then all the compliance history is wiped. They basically go back to the start of the process. If, however, they're found to be able to meet their requirements but unwilling, then they are progressed through the system. If they accumulate another 2 demerits, then there's a subsequent assessment by Services Australia or Centrelink. And again, if they're not capable, if there's anything new to disclose, they go back to the start of the process. If they are found capable, then they enter what's referred to as the penalty zone. And it's only after that point, so generally a person would have committed 5 failures by this point without a valid reason. It's only after that point that subsequent failures result in lasting financial penalties. So it is the design of all compliance arrangements are very much designed to be focused at those persistently and deliberately non-compliant. Cool. So now I think we should be on slide 5, just about if job seekers have difficulty meeting their requirements. So as Dan mentioned, requirements should be appropriate and achievable for a person's individual circumstances, and they can and must be adjusted if they are not. The legislation is pretty explicit that, that's the Social Security Administration Act, that a range of factors must be considered in determining someone's requirements. That includes consideration of health conditions, transport opportunities available, local labour market, caring responsibilities, and a range of other factors. And so requirements can and must be adjusted. If a person is temporarily unable to meet any requirements at all, for instance, if they become sick, or in an accident, major personal crisis, become homeless, domestic violence, a range of circumstances that impact their ability to meet requirements, they can apply to Centrelink for an exemption from requirements. Generally, those exemptions last for 13 weeks, although they can be extended and re-granted for as long as the circumstance continues for those temporary circumstances. And during that period, as I say, can't speak, people have no requirements at all. Cool. Oh, sorry. I'm just seeing the thing that I should speak a bit louder. Whoops. Hopefully I subconsciously got louder, but we'll have to see. There are, though, some differences when it comes to drug and alcohol related conditions. In 2018, the then government changed the Social Security Act, as it was then, now Social Security Administration Act, so that a person could not be granted an exemption if the reason for the exemption was wholly or predominantly due to drug or alcohol misuse. Similarly, there's some changes to legislative instruments that mean that when a person is being assessed for whether or not a penalty should apply, they cannot have a reasonable excuse if they've previously failed to meet a requirement for a reason due to drug or alcohol misuse, and then subsequently failed to participate in available drug and alcohol treatment that was appropriate for their circumstances. There are a range of exemptions to that criteria. For instance, if treatment is not available, if treatment is not appropriate for their circumstances, if they have tried to participate in treatment and it hasn't provided significant benefit, all those circumstances, then reasonable excuse can continue to be assessed as previously. And it is a criteria that in all but that particular circumstance where they've refused to participate in available and appropriate treatment, that drug and alcohol conditions, other medical conditions, impact of homelessness, language literacy, numeracy, and a range of other specified conditions must be considered by decision makers. Cool. And moving on to, I was just talking about removal of exemptions. But a crucial thing, that I didn't talk about with the removal of exemptions is that participation in treatment can be counted towards requirements, and also other requirements can be lowered if a person can't meet them because of the impact of a drug and alcohol condition. And I'll hand back over to Dan to talk about ESATs. Thanks, Dan.
Thanks, Andrew. So employment services assessments. When a job seeker discloses that they have a medical condition or a disability or an injury that impacts their ability to work, they may be referred for an employment services assessment. These ESATs, they're conducted by the same health and allied health professionals who also at Services Australia who also conduct the job capacity assessments for DSP purposes. So when they disclose that they have medium to long term, so anything really that lasts more than 3 months or 13 weeks, impacting their ability to work, they will undergo this this assessment. And there are two purposes. One is to determine the most appropriate employment service type. So that's, you know, should they go to disability employment services or to Workforce Australia services. Medical evidence generally must be provided, but a key difference between the assessments for DSP and for mutual obligations and employment services purposes, all medical conditions are assessed, not just those that are fully treated, diagnosed and stabilised. As a result of an employment services assessment, they may be assessed as having a partial capacity to work, which is work capacity of less than 30 hours per week, or they might be assessed as having a temporary reduced work capacity. So a partial capacity to work assessment is ongoing, and a temporary reduced work capacity would be for a period of less than 2 years, and they may be assessed as having this temporary reduced work capacity in order to undertake treatment, for example. Job seekers with a reduced work capacity have reduced mutual obligation requirements. So, for example, those in Workforce Australia, their points target will be automatically reduced from 100 to 60, and that can be reduced further depending on other things that might be impacting their ability to meet those requirements. If a person is assessed as having a reduced work capacity of less than 15 hours a week, then they generally become Centrelink managed, which means they agree to a job plan with Centrelink. They're not required to participate in employment services. The only requirement is to attend the participation interview quarterly with Services Australia. I think Andrew's covered reasonable excuse. I'll just go on now to talk about job seekers in residential rehabilitation. So where a person enters drug or alcohol residential rehabilitation, they're not required to meet the requirements set out in their job plan. So these are the requirements have to be adjusted, and the adjustments are made by their employment services provider, or in the case of people who are self-managing in Workforce Australia online, the Department of Employment and Workplace Relations Digital Contact Service Centre. Services Australia is not involved in the adjustment of their requirements because it's not an exemption. So Services Australia would, for those who are maybe eligible for an exemption, it's Services Australia that has the delegation to apply those exemptions, to assess and apply them. But in the case of people going to residential rehab, rather than an exemption, their requirements are reduced to nil while they're in the facility. So if the person is unable, once they enter, to contact their provider or the digital services contact centre, facilities have implied authority to contact either the provider or the contact centre on their behalf. to let them know when they entered, and once they're released, if they could also contact to provide that information if the person is unable to do that themselves. So essentially, like I said, while they're in the rehab facility, they shouldn't have any requirements other than to participate in the rehabilitation process. And that's about all we have for today. Thank you very much, and apologies for the technical difficulties. Hopefully, it was an informative session.
No, that was great, you guys, and thank you for winging it with the tech difficulties. Just for our audience that is predominantly in the NGO sector, we have an issue with the government IT systems where they don't like Zoom. So government IT systems prefer either Teams or WebEx. We've gone Zoom because that's what the majority of the NGO sector uses. But just so you know, the IT systems in government don't like Zoom. And so we're having an issue with the IT systems blocking access to some things. So it's not that Andrew and Dan don't know how to use this technology. They totally know how to do a PowerPoint presentation usually, but they're being thwarted by their IT systems there. So thank you guys for winging it. And thank you, Brett, our AV guy, who has just kind of helped us to show the slides as we freeformed it on that one. So what we will do as well, just reminding you guys, we will share these presentations online afterwards. So if there is a particular slide that you couldn't see, it was a bit small or it wasn't up for long enough, or we didn't get to it because of the tech difficulties, you will be able to look at these presentations online afterwards. But thank you, Andrew and Dan. That must have been a scary experience with the tech there. I totally appreciate. So thank you for bearing with us on that. What we are going to do now is throw to our panel session, and we do have some questions coming in from the audience, and thank you everyone for starting to punch those in. I can see that you can work the Q&A bit here. That's good. So everyone who has a question on any of those presentations so far, please start punching those into the Q&A and we will get to those. In the meantime, what I would like to do though is introduce our panelists and just give the panelists an opportunity to respond to the presentation so far, and also for them to add any other information, particularly the government people, to add any other useful information that they think provides something in addition to the presentations that we've got. So we have lost Alex. He hasn't been able to stay with us for the panel session, but we do have Nathan Dean, who is the Director of Carers and Disability Payments Policy Section, and Sarah Morris, who is the Assistant Director of the Disability Support Pension Project Section at DSS, available here to answer questions about Alex's presentation. And Nathan and or Sarah, I'll let you guys decide who's best one to answer my first question on this. I just think it's worth explaining a little bit more to the audience around the 20 points concept, because I know that's something that a number of clinicians have raised with me as being difficult for them to wrap their head around previously. So it's about when you saw that presentation and you see that the client has to get to 20 points, they need to get to 20 points on a single table to be able to get to that. Is it significantly impaired? Can you talk us through, Nathan or Sarah, that point system and what that means in terms of the way that clinicians need to use that to support an application? Nathan or Sarah, whoever you reckon is best placed to answer this one, go your hardest. I can see you conversing there in the background. Good on you. Pick a path, we don't mind. Whoever would like to answer that one, please do. And don't forget to unmute yourself when you answer that question as well, please.
Melanie, can you please repeat that?
Yeah, so the question, my first question was around that idea of 20 points in a single table. So in the presentation that Alex gave, it talked about the different impairment tables and the thresholds that needed to be got to, the 5 points, the 10 points, the 20 points. My understanding is that to get to a threshold for the DSP, you need to get to that 20-point mark. But is it the case that you need to get 20 points off a single table? Or for people with multiple disabilities, can you get to the 20 points off multiple disabilities? How does that point system work, is the question.
So to qualify for DSP, you need 20 points. If you obtain 20 points across one table, that qualifies as a severe impairment, and you qualified for DSP if you're assessed as being CITW, continuing inability to work. You can qualify for DSP across if you achieve 20 points across multiple tables. However, you do have to undertake a program of support before you are eligible for the payment.
Awesome, thank you. And we will make Alex's slides available on the website as well, because I think that provides some important clarification too. And I note that some of that text was a bit small for people to be able to see, so we will do that as well. Nathan and Sarah, was there anything else, any other points that Alex made that you wanted to underline or highlight in response to that presentation?
Yeah, Melanie, just one point. Off the back of Alex's presentation in relation to Table 6, I'd probably just make the point that eligibility criteria for DSP, including the impairment tables, have been designed to be as fair as possible. And all claimants are assessed based on their functional capacity, not based on their use of drugs or alcohol.
Cool, thank you. Did Sarah have anything that she'd like to add, or can we go on to our DEWR colleagues?
No, probably just to reiterate what will be seen at the end of Alex's slides. If there are any questions that pop up outside of this session, please feel free to email us at the email address provided.
Excellent, thank you. Now, Andrew and Dan, you guys had a hard time with the tech there. You probably were a little bit distracted by that. Are there any other key points that you would like to highlight coming out of your presentation?
Yeah, thanks, Melanie. I think probably the key takeaway is that it is employment services providers and the digital services contact centre who are responsible for setting requirements, and who any drug and alcohol treatment providers should contact in terms of having people's requirements adjusted, rather than Centrelink, who will just refer people back to providers in the case of drug and alcohol treatment issues, because they cannot grant those exemptions as we talked about.
Dan, you got anything you want to add?
Just that we've recently had some feedback that there's a bit of confusion from both from employment services providers in general about what should happen in these circumstances when someone does go into residential rehabilitation. So we're looking at reinforcing some of that messaging to the providers.
That's really great, because I note that a number of the questions I'm looking at that are starting to come in from the audience are about that, about those third-party providers, and they're not necessarily adhering to what was on your slide. So it's great to hear that that comms is going to be happening as well. I might throw now to Donald. Donald Walters is the Assistant Director of the Disability Pension and Parenting Payments Branch. And we've also got Jenny Rohan, who is the Assistant Director and also a clinical psychologist of Assessment Services at the Smart Centre Operations Division in Services Australia. Donald, I might throw to you first, and then we'll throw to Jenny. What would you like to add in terms of the content of those presentations, or any key messages from Services Australia?
Yeah, no, thanks very much, Melanie. And can you just, you can hear me okay? Yeah, good. This is on my iPhone, and yes, I do apologise to the audience for a lack of compatibility with Zoom. But anyway, it's working so far. Look, a couple of points is, and I'm just in the disability support pension space. There's a really great detail in the presentation about the eligibility requirements. I think it's useful to understand that, but we do not expect that people applying for DSP have to understand that detail. I mean, it's there. It's publicly available if people need to see it. But the main thing is that if a person for any reason can't work, the main thing is they have to put a claim in, but also just provide medical evidence about the how their condition, the conditions that most affect their work capacity. And so you don't have to tailor that around particular tables. You just have to say, well, if you've got a mental health condition, if you're impacted by current substance abuse condition or anything else, tell us about that circumstance and get as much detail as you can in the medical evidence when you lodge your claim. So I think that's an important takeaway. It's I think there are people who are interested in the detail, but you don't have to go and memorize that or do homework on that. And basically the information about claiming is on our website. So how to claim online, but paper as was covered. And just another point as well is I think in this presentation we're talking about people claiming DSP and also job seekers. And that's Dan and Andrew were talking about typically people receiving job seeker payment. They may be the same people. So you may have a person on job seeker payment who wants to test their eligibility for DSP, and those they can do that at any time. And we get a lot of people claiming are currently already on payment too, so they're not mutually exclusive. So we just, if they're applying for DSP, we look at the DSP rules when we're assessing that claim. So yeah.
Thanks, Donald. That's great. And I think, Jenny, you've probably got some different perspective to add being a psychologist. Are there any tips that you've got for clinicians in the audience about things they need to keep in mind?
Yeah, thanks, Melanie. Thanks, everyone. So I'm from the Assessment Services branch within Centrelink Services Australia, and thanks, Donald, for your explanation of things too. I just wanted to make a few points if I could. So our team of allied health professionals refer to all of the medical evidence that's made available for every DSP applicant, and we're really guided by that evidence in the application of the impairment tables, which we've heard about today already. Obviously, we're not the experts on the patient. That's the person's treating health professional and their treating team. And that's why the evidence provided is so crucial for our assessment and in the application of the tables. In the earlier presentation, we saw that there might be times where our allied health professional assessors may need to discuss an individual's functioning, treatment, prognosis with yourselves, the specialists and allied health staff involved with your client. And so we do appreciate your time in speaking to us when that's required. And just to let you know too that we've got internal processes to make sure that all applicants are assessed appropriately, to make sure that we're not missing things. So we really pride ourselves in making sure, if you like, that no stone is unturned with checking somebody's eligibility. So I really wanted to make that point today too. And we definitely appreciate your expertise with your clients in helping us make those decisions around applications for the tables. Thanks, Melanie.
Awesome. Thanks, Jenny. And I think that's really helpful too for people to understand how the processes work behind the scenes. So thank you for giving us a little bit of a peek behind the curtain, if you will, there. I'd like to introduce now Dr. Craig Rogers, who is a Senior Staff Specialist for Addiction Medicine at St Vincent's Hospital in Sydney. Craig is also the President-elect of the Australasian Professional Society on Alcohol and Other Drugs. And just so you know, Alex referred to the development of the AOD table in particular, and Craig was part of the working group that provided the track changes on that table that gave us the table that we have today. So first of all, we were very, very delighted and thankful to the Minister for deciding to keep the AOD specific table in the impairment tables for the DSP. And very thankful to Craig for his expertise in helping us to work with our colleagues to redraft that as well. So thanks, Craig, for all your hard work up until now. And I guess what I'd really like you to share, Craig, is some of the stories that you had. I mean, obviously, we've worked hard to try and change things moving forward, but I know as part of the consultations, you had talked specifically to DSS around some of the frustrations and challenges you'd had previously in getting clients of yours onto the DSP and getting their applications considered favourably. Do you want to maybe run through a case study of that, and so our colleagues could, you know, talk about how things might be different going forward in the future, or tips and tricks for how we might do things differently as clinicians in terms of those applications?
Sure. As you know, we've discussed, I mean, I must say I find the whole DSP process extremely frustrating and would rather not get involved in it if I didn't have to. Look, I really love supporting clients in it, but it becomes sort of overwhelming for people. I mean, particularly when they get refused and we've got to reapply. And, you know, there are some people who, I guess drug and alcohol might be one issue that they have, but with multiple other issues, they don't sort of quite have enough points in each area. But, you know, they've never worked in their life and they're now 40 and probably never going to. And so getting them over the line is a real struggle. And I must say, I have used the tables to try and address the criteria in them to make it a little bit clearer, because often, you know, what if you just write a simple letter, it's not enough. I mean, you've really got to give better evidence to help support them to get over the line. So having the tables is useful, but look, you know, it took me years to find those tables. There was a lovely social worker who found it for me. I wouldn't have had a clue where they were as a practitioner generally, and as a GP, you just don't have time to look up any of those sorts of things. A lot of the clients that we see now in drug and alcohol don't have a GP. GPs are much more difficult to access for clients with the lack of bulk billing. So it often does come down to drug and alcohol services. And then also a lot of the, I guess, disability claims want evidence from a specialist, whether it be drug and alcohol or a psychiatrist or a psychologist. So, you know, a simple letter from a GP may not be sufficient evidence. So I think they're difficulties for people. And when, I don't know if I'm the only doctor on the panel. I mean, Hester was supposed to be here. I'm not sure if she's here. But look, it's incredibly wonderful when somebody gets the DSP. I mean, it makes a huge difference to their life. That little bit of extra money, and so that's great for their mental health well-being. But I do find it a struggle and a frustrating process.
Before we throw to our colleagues to respond to that, Craig, I might just throw to Tony Eaches. Now, Tony has replaced Hester, who had some clinical, she's in Deniliquin delivering services. She's had to pike out on us at the last minute because she's got a clinic going and hasn't managed to escape. And Tony is the operations manager and deputy CEO of Goldbridge Rehabilitation Services in Queensland. And so Tony brings that perspective as a manager of a rehabilitation service in terms of the sorts of frustrations that you've talked about. Tony, is what Craig talking about, has that been an experience that you've had as well in terms of how residential services are able to interact with the system?
There's a few points, I suppose. I guess we're not necessarily, and I don't believe we can be, the medical specialist if a client wants to apply for the DSP, because we're the treatment facility and we need to be the treatment team. And once you start entering into that and you're doing that for the client and then they get a no, that just breaks our rapport and the trust with the client, because, you know, they don't trust Centrelink, then we're a part of that system. So that's not necessarily helpful. Of course, we do help them, but, you know, it's not ideal because we're trying to treat them for their AOD use. Obviously, we're dual diagnosis, but, you know, we're getting involved in other parts that we shouldn't need to. And I guess, and you know, it sort of spoils that therapeutic relationship when then they come back and it's like, no, and it's like, well, you didn't support me. We need to focus on the treatment and what we're doing, and not get caught up in the, you know, the Centrelink and stuff like that. I guess the other side of it, from an organisational point of view, we are reliant on user pay. Yes, we get funding, we get Queensland Health funding, we get Commonwealth Health funding, but we're also reliant on user pay. Users have to pay for the service. What we get funded through the government doesn't cover all our costs to deliver the service. So when people are having trouble either getting Centrelink, so it's a barrier to entering treatment, or they enter treatment, they may have an exemption for, you know, a small period, and then suddenly it gets stopped. You know, that affects our service. That's payments, because we're not then going to discharge the client. I'm sorry, your Centrelink didn't come in, you have to go. We're not going to do that. We keep the person, but then, you know, it's a big chunk that we're not getting paid, and that affects our service. So yeah, there's a few different aspects.
I think there's some really interesting points there. And Rebecca, before I come to you, we might just put a pin in it and take a few of those before we move forward. I think that's an interesting point you make, Tony, about the impact on the therapeutic relationship. And I'd be interested in Jenny's take on that, given her position as well, in that, I mean, it's interesting, and I'm sure it's interesting for the government people as well, that for clients, we're all part of the system that is problematic. Like, they don't necessarily differentiate government from non-government, or, you know, different government agencies, or NGO clinicians from government clinicians. It's that life is hard and the pathway to get to the answer is hard. So I think that's an important point. And Jenny, I might ask you to respond to that one. But also, I take the point that Tony's making as well, that people's Centrelink payments do contribute to their treatment. So it is important that we find a way through, so that treatment services can communicate that people are engaging in treatment so they can continue to get their payments. That's important. And I'd also be interested in a response from our DSS colleagues around the points that Craig made, and whether you think the tweaking to the new tables will actually make it better. So I think, Jenny, we might start with you about therapeutic relationship, and then we might head over to DSS and DEWR colleagues to throw their two bobs worth in as well, before we go to Rebecca for her reflections on the presentations. So
look, thank you, Melanie. Really excellent points, Tony. And we do hear that. We hear that from specialists. We hear that from GPs, that, you know, therapeutic relationships, people are concerned about letting Centrelink know about restrictions people have. I think the key thing for us is we're relying upon your opinion in terms of prognostic things. We don't know, and that's another part of the discussion that has to happen around how ongoing the condition is, whether it has been reasonably treated, and we're not we are sort of looking for your advice around those answers. Certainly. Look, I'm not sure of the nature of your service or those sorts of ongoing relationships that you have, but I guess, you know, if I was in similar shoes to yourself, I'd potentially be saying, look, you could comment about treatment participated in to date, you could comment around their level of functioning and what you might anticipate the future might look like with treatment. But certainly it's a point that gets raised with us by numerous practitioners, but at the end of the day, you're not responsible for the legislation around the criteria and the eligibility. And again, when it's really helpful, we see great outcomes for clients, shared clients that really aren't appropriately, you know, or unappropriate to be on something like a youth allowance or a job, you know, a job-related mutual obligation payment. DSP really is the best option for them, and usually they're the clients that aren't new to treatment. They've usually been in multiple times, those sorts of things. So, but again, it is a quandary. I appreciate that practitioners experience that, and again, we can't really answer those questions around eligibility without liaison from you as experts. So yeah, it's twofold, absolutely.
Before we go to the next part of that with our DSS and DEWR colleagues, I just want to acknowledge that communications is coming up as a big thing in the questions online as well, in terms of clarity. And I think, you know, Craig's point was, we're clinicians, we're trying to do clinical work, we don't have time to Google where all these forms and stuff are and the policies and the tables and the blah-de-blah. So I think we might just take as a given that we as a sector and as government agencies as well probably need to do a bit better in terms of the visibility and comms on how people engage with the process. And I think that's one of the important points that in our conversations leading up to this event, we're very committed to working with our government colleagues around creating further clarity in terms of these government processes. I might throw to our DSS colleagues now, though, and talk specifically around the new AOD table and whether you think that will be better or worse than the previous one in terms of being user-friendly for clinicians and how you think that is. I mean, we hope it's better. We put track changes on it.
Well, you set me up there, Mel. I just wanted to thank yourself and Craig and anyone else on the session who you know, participated in the review and had feedback on the table itself. So key changes made to Table 6 were made to better represent the functional impacts experienced by people who do have substance use conditions. Largely, the feedback that we've received in regards to the changes to that particular table have been positive. So time will tell how that plays out as it stays in place for the next 10 years. But we think we're on the right track with the changes that have been made.
Thanks, mate. And thank you for all your work. You have been part of this certainly since I started the conversation. So thank you for all the extra hours that you put in to reviewing that table as well. We really appreciate that. DEWR, do you guys want to throw 2 bobs worth in about any of the stuff we've talked about so far?
Thanks. I think one thing I guess worth just emphasising is we are very aware about the impact on people's payments from some of these processes going wrong, and we are trying to put in place as many processes as possible to minimise the risk that could potentially occur. No process is foolproof, particularly with the thousands of moving parts and different employment services providers and organisations that are out there. But you know, we are trying to put as many processes in as possible to minimise that risk. And as Dan mentioned, one of those things is increased communication that is happening at the moment. Another, I guess, avenue available if processes do go wrong, we have the National Customer Service line where people can phone up, and if providers are not doing what they should, then that's an avenue where you can say, well, this is what the provider told me, it doesn't seem right, and that can be adjusted by the our line. Should be able to get the number for that out. But I guess the other thing as well is just as a government department, you know, we regularly brief government on policies. So if there are any systemic issues or case studies that you think would be helpful to sort of, you know, identify where processes are failing, we are very, very happy to receive those. You know, I guess we can't fix problems that we don't know are occurring, or you know, if it's a, you know, issue with the individual provider or an individual process, or if it's something systemic, then both of those can allow us to come up with ways to fix those issues, which is ultimately what we all want at the end of the day.
Thanks, Andrew. And I think, you know, what we can do as well is publish that helpline number under the recording for this event on our website so that people have that. And certainly everyone has my email address, or if they don't, you can find it on our website, melanie.walker@aadc.org.au. It's pretty predictable. If you have any of those case studies that you'd like to share with our colleagues, I'm really happy to pass those on after the event as well. Now, we might now go to Rebecca Lang, who's the Deputy Chair of my board and also the CEO of the Queensland Network of Alcohol and Other Drug Agencies, or QNADA. Beck has been around in the sector for some time and has watched different iterations of these systems come through. Beck, what are you hearing from your members, and what's your feeling after hearing those presentations and the answers so far?
Yeah, thanks, Mel. And thanks to everyone who did presentations today. I learned a couple of new things, as I always do when I engage with these systems. And the thing that I think occurs to me is that we tend to do these communications processes and stops and starts. Like we had some really great engagement with the same group of departments. I think it was back in 2017 when we first started to hear from members that the adjustments to the demerits kind of process, which is still a really complicated process from my perspective, was impacting on people accessing services. So, you know, we know that when people are experiencing difficulties around their substance use, the likelihood that they're going to get diagnosed with a substance use disorder or with drug dependence is fairly low, because there's just not that many psychiatrists and addiction medicine specialists in the country. So for the vast majority of people who enter treatment, and that includes, particularly in this instance, I think residential treatment, they're not coming with a preloaded diagnosis nor access to the types of medical supports that would be able to get them that diagnosis. So the far more likely experience is the one where they're seeking to be excused from their mutual obligations for the purposes of being in treatment. And so I'm pleased to hear that that should be a fairly straightforward process, but we hear from our members that it's not often. And that, I think, comes down to those, I think they're now called employment service providers. Back in the day, they were called job service providers. It really only takes one person within one of those regional services to decide that this is how we're going to interpret the rules, and it can create havoc in the treatment system. I mean, as Tony said, the sad fact is that we don't fully fund treatment services in this country. Why? I don't know. That's a conversation that I think is worth having. But as a result of that, we are, as a health system, reliant upon Centrelink payments being seamlessly continued in order to provide stable services for the community. And I think that reflects the stigma associated with drug dependence. This idea that you should be contributing to the cost of your treatment because then you'll value it more. There's a lot of things to unpack. I think at this moment, what I'm pleased with is clearly the huge amounts of goodwill that there are to minimising those experiences and maximising the seamlessness of the system. And I wonder how we can build in some structures to make sure that we're continuously kind of topping up the workforce on both sides of the fence about what the expectation is, because, you know, we know these days people move around a lot. And so we might provide a guideline, and then a year later, the workforce has sufficiently shifted that maybe there's no one left in one of those ESPs who understands that guideline exists.
Thanks, Beck. And I think there's a couple of things to unpack there. Andrew and Dan, I might just throw to you guys for a view on this, because not being in the AOD sector, something that we understand is that for a long time, and there was a report commissioned by the Department of Health and Ageing, as it then was back a while ago, that said that in any given year, there's about 200,000 people engaged in drug and alcohol treatment, but there's another 500,000 people who can't get in because of a lack of capacity in the system. And that's what Beck's alluding to there. Sometimes you're going to have people who know they have a drug or alcohol problem, they're trying to engage with treatment, but they haven't been able to do it yet. Is there any thought about that at a policy level and what the implications of that are in terms of people's mutual obligation activities while they're waiting? Is it you guys who I should throw that to, or do you want to throw someone else?
Yeah, that one is us. I mean, I guess more broadly than alcohol and drug-related issues, people on unemployment payments have a range of issues. There's a significant number who might be, at risk of homelessness or experiencing domestic violence, or basically there's just a huge gamut of issues that may be affecting circumstances. But sometimes those result in exemptions from requirements, but particularly for the sort of more long-standing issues where it's less of an acute, I can't meet any mutual obligations right now, and more a case of my requirements need to be adjusted. But that is, I guess, a sort of a day-to-day job for employment services providers to really like work with an individual and make sure that their requirements are appropriate and achievable. And that's why in the compliance system that we were talking about before, there are so many sort of checkpoints in there to make sure that someone isn't facing penalties for not meeting requirements that are potentially inappropriate. Obviously, the goal is to make sure the requirements are appropriate from the outset, and have those conversations with the person to like, what are your circumstances? What are your goals? How do we get there? But historically, there's been quite a lot of issues of people not disclosing issues that are affecting their ability to meet requirements until they start to interact with the compliance system, and so that's why a lot of those checkpoints are built in, so that they're not facing lasting financial penalties before they're really, I guess, prompted to again disclose that information. So I would say it is a pretty core and constant policy consideration for us, both with regard to alcohol and drug related issues, but also much more broadly for issues affecting people's capacity, mental illness, disability generally, whole range of factors feed into that. Dan, I don't know if you had anything to add to that.
Thanks, Andrew. Only that providers do have the discretion to adjust requirements based on their knowledge of the person's circumstances. If it's unreasonable for them to meet requirements, they can adjust them. So they're not necessarily granting, having an exemption granted per se, but for all intents and purposes, if they're aware that the person cannot meet their requirements for one reason or another, and we expect the providers to temporarily adjust their requirements under those circumstances.
Yeah, and actually just building on what Dan said too, also a huge amount of discretion in determining if someone has a good reason for not meeting those requirements if they've previously been set and then additional information comes out.
I think that's really
have to change that now.
And also, Andrew, this helpline that you're talking about, because I think what I'm getting from the questions is that everything you're saying sounds good, but the experience of that where the rubber meets the road doesn't, like the operationalization of the policy doesn't always match what you guys are saying in terms of the policy intent. So having that ability to ring a helpline, and not job, but to point out when perhaps a provider isn't adhering to that the spirit of the policy, I think gives people an extra check and balance. And we will publish that helpline on our website after this event.
Yeah, excellent. But there's definitely some cases where, because there's so many providers, there's going to be some where a particular individual is not doing what they should be, not following the policy. So absolutely calling that number is the right thing to do.
I think that's great. And we've answered quite a lot of the questions in the discussion that we've had so far, but let me just go to some of these audience questions with some specific examples. So just what we were talking about there in terms of that discretion and temporary exemptions, or allowing people to have, some flexibility around that mutual obligation. A specific issue that's been brought up is around relapse. So we know that in many instances, drug dependence is a chronic relapsing disorder. So someone might be doing well for a while and then they have a bit of a stumble, but it doesn't mean necessarily that they need to go on the DSP and they won't be good soon. Does that discretion that you're talking about extend to those relapse or lapse scenarios?
It does, absolutely. Requirements need to be adjusted for circumstances at the time. So if someone does relapse, then those requirements should be adjusted. The same rule about Centrelink not being able to grant exemptions for reasons wholly or predominantly due to drug or alcohol misuse does apply as well to relapse. So it's a case of adjusting requirements rather than exempting from requirements altogether.
Excellent. So just going back over some of the points that we've made before, There's one question here that speaks about how in remote communities it's extremely hard and challenging for participants in full-time AOD residential rehab to focus on recovery and trying to work on their requirements while they're having mutual obligation requirements. Is it as simple as residential rehabs just informing someone that someone is in treatment? Is that it? Because going back to what Tony was saying, if it's as simple in terms of mutual obligation exclusion as being able to go, someone is here, they're doing this, they'll be here for this long. If it's that simple, who do people tell so that everyone who needs to know knows?
Yes, so that in that case, they should contact the person's employment services provider, or if they're in digital services, then it's the digital services contact centre. And in that case, requirements should be fully met by that treatment participation. There should be no other requirements on the person for the period.
And then we jump to the helpline if it doesn't work, right?
That's right.
Can I just ask, do they need a doctor's certificate or medical certificate for that?
No medical certificate should be required, just time of treatment participation.
Okay.
Can I just comment that we do that, depending on which I think has been alluded to already, depending on the employment service is what response you get. Depending on the individual worker is what response you get. There's a huge amount of stigma, and you just have to get that one person who has a problem with anybody who may have an AOD issue. And their attitude can be, you know, really discriminatory, and they're not helpful. They don't want to help, and they're certainly not going to give somebody an exemption because, you know, their attitude is, why should you? Because you're a drug addict or you're an alcoholic, and this is what we come up against. It was good to hear that, you know, there is going to be some education of job network providers, but it's a real issue for us, and there's so many of them now since they were given this power in, I think, 2018. So many new ones popped up, and it is very difficult now, you know, to try, and you can't guarantee which job network that your client is with. It's not easy to move. So like, we have some that are really supportive, others that are just shocking to work with, but you can't just say to the client, oh, you know, go to this person, because it's not that easy to move job work network providers either. So it's the stigma, I think, often, and that might be the individual, not necessarily the organisation. So I think there's a lot of education needed.
I think that's an important point and something that our colleagues can take away. But in the interim, I think it's great, and we need to advertise as broadly as possible this helpline that people can ring, so that when they have that experience, there is a third party that can intervene. I think that's our answer in the short term. Now, in terms of helplines, so this one might be one for DSS or Services Australia. This is another question, but around DSP applications. Is there a helpline or something like that that individual social workers, caseworkers can ring to talk through a client's individual needs and the assistance, whether they're eligible for DSP or whether job seeker is a better course of action, and which way to go in terms of which payment is most appropriate? If you've got a client, you're not sure whether DSP is applicable or whether you should be seeking temporary exemption from job seeker mutual obligations, who are you going to call about that? Someone from DSS or Services Australia, can you answer that question?
I think it might be better for more of a Services Australia one. I think you're checking. Yeah, we don't have a dedicated phone line for that particular sort of circumstance. I mean, but if you're talking about somebody who's acting as an advocate, nominee, support person, there is they can certainly ring the normal like the disability line at 132717, where that's the same line as customers would call. So and obviously that can be, you know, it can be busy sometimes, so we are well aware of that. But yes, it's at this stage we don't have a dedicated third party in phone entry point, if that's what you're asking. Is that understood the question? but we can definitely help people who just contact through the number. If of course if they're wanting to talk about circumstances, we'd have to do with authority and permission to inquire and that sort of thing. But just depends on the nature of the advice being given out.
Thank you. I think this question that we've got here is a little bit different from some of the others, and I'm conscious that we're nearly on time, so I'm going to throw this one in. It talks about how it's common for people engaging with alcohol and other drug services to have limited access to telephones and internet. So we're talking about a digital divide issue, and I guess issues around poverty more broadly. So when they're calling providers at their appointed time through a phone that they've borrowed from someone, and then they can't get through, it impacts on their ability to comply with mutual obligation activities. Have you guys had any thoughts about how we deal with that for clients that are particularly marginalised and disadvantaged in terms of ensuring that the communications they need to engage with are accessible?
So while they're in residential rehab, they should not have any requirements, no appointments with providers, essentially nothing apart from the treatment itself. The only contact they should be making is to let their provider know that they've entered residential rehab, and like I mentioned earlier, the facility can contact on their behalf to let the provider know. If there are any issues around that, if the provider isn't reducing the requirements and is insisting on additional requirements, then the National Customer Service line, which is within the Department of Employment and Workplace Relations, can be contacted, and that goes for people that are in Disability Employment Services or Workforce Australia services, and the NCSL. Sorry, that's short for National Customer Service Line. They will take that up with the provider if anything needs to be rectified.
Thank you. And just because we're just about dead on time, I'm going to sneak one last question in, but we will provide the information. We'll put the presentations up on the website. We'll also provide these numbers that have been referred to by our colleagues in this, and any handy links that they think might be helpful, we'll put up on the AADC website under the recording of this event as well. And just one last sneaky question here, because it's a bit different to the others that we've got so far, and it relates to the different mutual obligation activities that might be applicable for people on DSP versus job seeker. So it goes a little bit to the difficulties in dealing with job providers, but what's the difference? Can one of you talk us through what is the difference between the mutual obligation activities that are applicable for people on the DSP versus the requirements for someone that are currently on job seeker? Who wants to take that one? Last one, I promise.
Melanie, I can just speak on behalf of DSP and just say that rehabilitation programs count as mutual obligations for DSP purposes.
In terms of the broad difference between mutual obligation requirements for the different payments, they are very different. So they're legislatively entirely separate. The mutual obligations for job seeker youth allowance, parenting payment, and special benefit, they all have the targeted compliance framework apply if they aren't met, and the sort of the scope in the legislation is very general. It's just about movement towards employment, and then the sort of the broader policy of participation in employment services sets what a person's specific requirements are, and usually that is a requirement to look for work, meet a points target, and the like. Whereas, and DSS, correct me if I'm wrong, for DSP, those aged under 35 might have a requirement to meet one activity, but what that activity is also pretty general, and then may involve requirement to participate in employment services. But this is a bit of a actually difficult question, because it does sort of go across different departments, but broadly that is the distinction between the payments. Unless DSS want to jump in and add to that.
Can I just add a note? Is that all right? Just sort of saying, just for DSP, and just to add to what Nathan was saying, but most people on DSP don't have don't need to meet participation requirements. It's only if you've got work capacity assessed at least 8 hours a week. So, but if you do, it's sort of it's quite a different. You generally can choose the type of activity that you want to do. So, for example, you're not. If you prefer to do something like volunteer, it just has to be a work-focused activity. So it doesn't mean that DSP customers are like forced to participate in DES or Workforce Australia or anything like that. So it's sort of a much lighter touch regime than mutual obligations for other job seekers. Yeah.
Thanks, Don. And I think we're going to wind up because we are slightly over time. Thank you, everyone, for coming along this afternoon and participating in this. As I've said, we're going to put the presentations and some supplementary information up on the website afterwards. And I think I'd just like to finish by sharing something that's come in on the Q&A, which I think is less of a question, but more of a statement, and goes to that conversation that we are opening up with DSS and DEWR and Services Australia, and how we'd like to continue that conversation going forward. And the question is around employment providers' awareness of what happens in AOD residential rehabilitation. So the question that we've got is, do they understand, do the employment providers, are they aware that we do work therapy skills, we do relationship skills, we do cooking, we do a whole heap of stuff in AOD residential rehabilitation beyond the actual AOD clinical treatment intervention? And I think that's something worth thinking about in a policy way going forward in terms of what people are actually getting out of this. And perhaps there's a way for these systems to interact more closely with the AOD residential service system, because people are doing a heap of stuff when they're in AOD Resi Rehab, and perhaps there's more of a closer link that we can provide with that employment pathway for people who are leaving AOD services going forward. So not a question, just an observation and something we might want to think about going forward. But I'd really like to thank our colleagues from DSS, DEWR and Services Australia. You guys aren't in the health field, and we really appreciate you coming along to learn more about the challenges that are facing our sector. And I'd also like to thank Craig and Tony and Beck for coming along and being on the panel and sharing their experiences from the work that they've done today as well. So we don't see this as the end of the road. We see this as the start of a conversation. And certainly as AADC, we've been really delighted in how your agencies have been willing to talk to us about our particular issues. We know you get spoken to a lot of the time by people with numerous issues, but thank you for engaging in ours and for being so thoughtful about how we can achieve better outcomes for the communities that we serve going forward. So thanks, everyone, and we will see you at our next online event. And in the meantime, we'll continue the conversation via the website. Thanks, everyone. Have a good day.